Assalamu alaikum. Hello, my dear students. I hope that you are all right by the grace of Almighty Allah. Today, I shall talk to you about rheumatic fever. And you have know about the rheumatic fever, but I shall talk to you about the nutshell of rheumatic fever, which is necessary for the written and viva question. The learning objectives of this lecture that you will know about the rheumatic fever, what is definition, pathogenesis, epidemiology, pathogenesis, then clinical features, diagnosis and management, and how to prevent the rheumatic fever. Rheumatic fever is an immune-mediated disorder. Usually develops 2 to 4 weeks after an acute episode of group A beta hemolytic streptococcus, and usually from pharyngitis. And peak age is from 5 to 15 years. And this 5 to 15 years is also called the streptococcal age. The other diseases which are caused by the streptococcus occurs during this period. Clinical manifestation and diagnosis: no clinical or laboratory findings is pathognomonic for acute rheumatic fever. However, there is revised Jones criteria for the diagnosis of acute rheumatic fever, which was made in 1992. And the major criteria are migratory polyarthritis, Carditis, Sydenham Chorea, subcutaneous nodules, and erythema marginatum. And these are the picture that what are the major criteria. That is arthritis, carditis, subcutaneous nodules, erythema marginatum, and Sydenham Chorea. Now, what is migratory polyarthritis? Typically, large joints are involved, that is knees, ankles, wrists, and elbow. Joint becomes swollen, becomes red, hot, and exquisitely tender, and movement is restricted. That is, you will get all the features of inflammation. And the arthritis of rheumatic fever flees from one joint to other. That means when one joint is affected, and after 2 to 3 days, when the pain is more or less subsided, the other joints involved. And for this reason, it is called fleeting polyarthritis. That is, an affected joint can become normal within 1 to 3 days. Carditis. Rheumatic carditis is characterized by Carditis. That is, it involves the pericardium, myocardium, and endocardium. Endocarditis, the features of endocarditis is soft heart sound, and murmur due to valvular involvement. And when there is myocarditis, the heart sound becomes muffled, and there may be cardiomegaly, there may be arrhythmia, and there may be conduction defect. Pericarditis is either dry pericarditis, and in that case you will get the pericardial rub, or there is pericardial effusion. And if there is pericardial effusion, the important signs in the pulse, that is, you will get a pulsus paradoxus. That means the pulse volume diminishes during inspiration. Normally, the pulse volume increases during inspiration. So this is called pulsus paradoxus. And in the pericardium, in the chest you will get the heart. In the heart cardiac area, you will get imperceptible apex. You will not get any apical impulse. And when you will not get apical impulse, you have to do the percussions of the heart area, and in percussion the area of cardiac dullness is increased. And when you auscultate, you will get that the heart sound is distant. Sydenham's chorea, this is also an important feature, and this feature is itself is the diagnostic criteria of rheumatic fever. In this case, you will get the emotional lability, incoordinations, and involuntary movements. And involuntary movements, when it affects the face, you get the facial grimacing, and it is social disagreement and social harassing condition, because when a child or young adult causing grimacing, then the other may feel embarrassing. And there is school performance will be poor, and the deteriorations of handwriting. And sometimes the Sydenham's chorea is diagnosed, and the prognosis or the progress of rheumatic Sydenham's chorea is assessed by the handwriting. And the clinical features of Sydenham's chorea, when you make handshake with the patients, the patient's grip will not be a constant one. It will relax, and there will be normal grip, but with immediate relapse, immediate relaxation. That is contraction and relaxation. The movement which is done by the milkmaid during the milking from the house. And there is spooning and pronations of hands when the patient's arms are extended. If you extend your arms, then the patient will be protected like this, and the hands will be extended. And warmier or darting movement of the tongue upon protrusion. When you ask the patient to protrude his tongue, he will not be able to keep the protruded tongue normally. That is, he will do like this. And you know that this type of movement is called darting movement, and it is the movement of the tongue of snake. The subcutaneous nodules. These nodules are small, firm, and most often found over the bony prominences like occipital region, olecranon, humeral condyles, knees, knuckles, and malleoli, or you may get in the tendon sheaths on the flexor aspect of the wrist and dorsum of the feet. The subcutaneous nodules may also be found in the cartilage, and this visible cartilage is in the ear cartilage of the external ear. Sorry. Erythema marginatum. Rash with map-like defined erythematous margins and pale centers which changes the shape continuously. And it is very transient that usually found over the tongue and the extremities. You see the pictures of erythema marginatum. The outside is the erythematous, in the center there is pale. Now, what are the investigations that you can perform for the diagnosis of rheumatic fever? And the most important one is CBC. You will get polymorphonuclear leukocytosis and high ESR. CRP is raised, and if you do the exercise test may be normal or there may be cardiomegaly. And ECG, you'll get the features of heart block, and most important was is a PR interval, the prolonged PR interval. and echocardiography to detect the evidence of carditis. And throat swab to be taken for culture to see the evidence of streptococcal infection. And in the blood, you have to do the ASO titer, that is anti-streptolysin O titer. This is increased and it is usually more than 200 units. This is the ECG. You see that there is PR interval, prolonged PR interval. And this is about the major criteria of rheumatic fever. Now the minor criteria. The fever and the characteristics of fever, of rheumatic fever, is the temperature up to 100 degrees Fahrenheit in 2 occasions in a day, either or in the morning and in the evening, or that is more than 101 degrees Fahrenheit in a single occasion in a day. Arthalgia, there may be pain in the joints, but if there is arthritis, the arthalgia should not be taken as minor criteria. And elevated acute phase reactant, that is increased ESR and increased CRP. The prolonged PR interval in ECG. Now the evidence of antecedent group A streptococcal infection. You have to find it by microbiological examination, positive throat swab, or rapid streptococcal antigen test, or serological, elevated or increasing streptococcal antibody titer, anti-streptococcal antibody titer, which is in short called ASO titer. Now, what are the importance of this criteria, the major criteria, minor criteria, and the evidence of streptococcal infection? If there is 2 major criteria that fulfills the diagnosis of rheumatic fever, or 1 major criteria and 2 minor criteria, plus evidence of recent streptococcal infection. After the diagnosis, you have to give the treatment of the patient, and the treatment is counseling first, and after counseling, the supportive management. This is the bed rest. The patient to be kept in bed till the joint pain persists or there is evidence of carditis. And antibiotics. 1 antibiotics is important for the treatment and for the prevention of rheumatic fever. That is penicillin. You can give either oral penicillin or injectable penicillin. And the penicillin, oral penicillin, phenoxymethyl penicillin, 250 mg per oral 6 hourly for 10 days. Or erythromycin, 40 mg per kg per day, same per oral 6 hourly for 10 days. Or single intramuscular injection of benzathine penicillin, 6 lakhs units for the child below the below the weight of 30 kg and 12 lakhs units over 30 kg body weight. And please remember that in the treatment management, it is said that a course of penicillin or erythromycin is given to eradicate the streptococcus from the primary site. And anti-inflammatory drugs. The most common and efficient anti-inflammatory drug is aspirin. If there is arthritis, aspirin should be given for 4 weeks. If there is arthritis and carditis, but without cardiomegaly and congestive cardiac failure, sorry. In that case, the aspirin should be given along with penicillin, and it should be continued for 6 weeks. And the treatment of Sydenham's chorea, as I said, that Sydenham's chorea may be the only one feature that diagnosed the rheumatic fever. So its treatment is a bit different, but the simple is simple. The treatment is very simple. You have to give the phenobarbital 5 mg per kg per day, and this phenobarbital is the drug of choice. And if the phenobarbital fails, you can try it with haloperidol or chlorpromazine. The most important aspect of treatment or the prevention of rheumatic fever is important. That is, prevention of rheumatic fever and its recurrence is important aspect of management of rheumatic fever. And there is one is the primary prevention. That is, when there is streptococcal infection in the throat, a course of penicillin or erythromycin should be given for 10 days, and it will prevent the occurrence of rheumatic fever. And secondary prevention. I'm sorry, I gave a pause. Welcome you again. And the secondary prevention, that is, once the rheumatic fever occurs, the rheumatic fever, like others autoimmune disease, is a remission and relapse. And rheumatic fever also relapse. To prevent the relapse, the treatment which is given is called secondary prevention or secondary prophylaxis. And in that case, the penicillin, either oral, should be given 250 mg BD or 125 mg BD if the weight is less than 30 kg or more than 30 kg. Then benzathine penicillin, same 12 lakhs unit over 30 kg and 6 to 9 lakhs unit less than 30 kg. And benzathine penicillin should be given every 3 to 4 weeks. And how long this prophylactic penicillin should be continued? Rheumatic fever without carditis, 5 years or until the age of 22 years or 28 years, whichever is longer. And rheumatic fever with carditis, but no residual heart disease, that is, no valvular disease. The penicillin should be continued 10 years after the attack or after the age of 30 years, whichever is longer. And rheumatic fever with carditis and residual heart disease, or there is persistent valvular disease, the penicillin should be continued for lifelong. This is in short about rheumatic fever, and there may be some question for MCQ like the following are the major criteria of rheumatic fever, and in that case or in that question 2 or 3 may be positive and the 2 or 3 may be negative. So I have to find out. And the another question is diagnostic criteria of rheumatic fever. So please try to remember the rheumatic fever and different aspects of rheumatic fever which I mentioned. In the first in this first slide, that is what are the objectives of learning rheumatic fever. Thank you very much.